Hello everyone. Today I'll be reading for you guys renal embryology and anatomy. So let's start with the renal embryology. Now there are three stages of the renal embryology: pronephros, mesonephros, and metanephros. Pronephros occur at the week 4 of development and then regenerates. Mesonephros occur at the week of 4 development, function as an interim kidney for the whole first trimester, persist in the male genital system is the Wolffian duct forming the ductus deferens and the epididymis, while the last one is metanephros, which is a permanent kidney, and it first appears in the week 5 of development. Nephrogenesis is normally completed by the week 36 of the gestation. Now there is a ureteric bud, which is metanephric diverticulum. So it is derived from the caudal end of the mesonephric duct, give rise to the ureter, pelvises, calyxes, collecting ducts, fully canalized by the week 10 of the development. And while metanephric mesenchyme, which is a metanephric blastema, it is a ureteric bud, interacts with this tissue, and interaction induces the differentiation and formation of the glomeruli through the to the DCT. So from the glomeruli to the DCT, it is contributed by the metanephric mesenchyme, and from the collecting duct to all the way to the ureter, it is formed by the ureteric bud. Then, if aberrant interaction between these two tissue may result in the several congenital malformation of the kidney, which is a renal agenesis and the multicystic dysplastic kidney. Now, ureteric pelvic junction, which is it is a last to canalize, and it causes congenital obstruction, can be unilateral or bilateral. Most common pathological cause of the perinatal hydronephrosis, and it is usually detected by the perinatal ultrasound. So now the Porter sequence, it is basically oligohydramnios, which is causing the compression of the developing fetus, and it is leading to the limb deformities, facial anomalies, which is a low ears and the retrognathia and the flattened nose. Compression of the chest and the leak of the amniotic fluid aspiration into the fetal lungs, leading to the pulmonary hypoplasia, and it is causing the death. Now, it is usually caused by the chronic placental insufficiency or reduced renal output, including the autosomal recessive polycystic kidney disease, obstructive uropathy, which is the posterior urethral walls, and bilateral renal agenesis. Now, the Porter sequence is associated with P for pulmonary hypoplasia, O for oligohydramnios, T for the twisted face, T for the twisted skin, E for the extremity defects, and R for the renal failure in utero. Then there is a horseshoe kidney. So inferior poles of the both kidney fuse abnormally as they ascend from the pelvis during the fetal development. Horseshoe kidneys get trapped under the inferior mesenteric artery and remain low in the abdomen. Kidneys can function normally but associated with the hydronephrosis, which is due to the ureteropelvic junction obstruction, renal stones, infection, and it can lead to the increased risk of the renal cancer. So it is higher incidence in the chromosomal aneuploidy, which is Turner syndrome, trisomy 13, 18, and 21. So basically, kidney develops in the pelvis, and when during the ascent of the kidney, this problem occurs. Now, there is a congenital solitary functioning kidneys. Condition of being born with only one functioning kidney, majority asymptomatic with compensatory hypertrophy of the contralateral kidney. But anomalies in the contralateral kidney are common, often diagnosed prenatally through the ultrasound. Unilateral renal agenesis. Ureteric bud fails to develop and induce the formation of the metanephric mesenchyme, which leads to the complete absence of the kidney and the ureter. Then there is a multicystic dysplastic kidney, which is a ureteric bud develops but fails to induce the differentiation of the metanephric mesenchyme. This leads to the non-functional kidney consisting of cysts and connective tissue, predominantly non-hereditary and usually unilateral. Bilateral can cause even the Porter sequence. Duplex collecting system. So bifurcation of the ureteric bud before it enters the metanephric blastema create a Y-shaped bifid ureter. Duplex collecting system can alternatively occur through two ureteric bud reaching and interacting with the metanephric blastema. Now strongly associated with the vesico-ureteral reflux and or ureteral obstruction. It increases the risk for urinary tract infection. It is frequently present with the hydronephrosis also. Now, the posterior urethral walls. It is the membrane remnant in the posterior, which is a prosthetic urethra in the male. Its persistence can lead to the urethral obstruction also. Diagnosed prenatally by the bilateral hydronephrosis and dilated or the thick walled bladder on the ultrasound. It causes the severe obstruction in the fetus associated with the oligohydramnios. It is the most common cause of the bladder outlet obstruction, especially in the male infants. Vesico-urethral reflex. It is a retrograde flow of the urine from the bladder toward the upper urinary tract. It can be primary due to the abnormal insufficient insertion of the ureter within the vesicular wall, which is a uretrovesical junction, or secondary due to the abnormally high bladder pressure resulting in the retrograde flow through the uretrovesical junction. It increases the risk of the recurrent UTIs. Now, the renal anatomy. So, first one is renal blood flow. So, left renal vein receives two additional veins, which is from the left suprarenal and left gonadal veins. Renal medulla receives the significantly less blood flow than the renal cortex. This makes the medulla very sensitive to hypoxia and vulnerable to the ischemic changes. Left kidney is taken during the liver donor transplantation because it is a longer vein, renal vein. Now there is a picture of glomerular anatomy in which the filtration barrier consists of the podocytes, which is a visceral layer, basement membrane, and the fenestrate capillary endothelium. Then there is a course of the ureters. Course of the ureter arise from the renal pelvis, travel under the gonadal arteries over the common iliac artery and under the uterine artery, which is the vast difference, retroperitoneal. Gynecological procedure, that is a ligation of the uterine or ovarian vessel, may damage the ureter, which leads to the ureter obstruction or the leak. Bladder contraction compresses the intramural ureter, preventing the urine reflux. Now, the blood supply to the ureter. So, proximally it is by the renal arteries, middle it is by the gonadal artery, aorta, common and internal iliac artery, and distally by the internal iliac and the superior vesical arteries. Three common points of the urethral obstructions are uretropelvic junction, pelvic inlet, and the uretrovesical junction. So that's it for the renal anatomy and the embryology. I'll see you guys in the renal physiology lecture. Until then, like, share, and subscribe.